Real light, please.
Good evening, all, from the AIOS. Today, we will have a wonderful discussion on walk-in patient with hypopyon in the first week after cataract surgery. So we will be moving through how to diagnose, triage, and manage. So we have with us two eminent chair people. One is none other than Dr. Jeevan Singh Titial, my teacher. He was chief of RP Center, now currently in Agarwal, heading the center, and he is the president of the AIOS. Welcome you, sir.
Thank you.
And we also have Dr. Rajiv Sukumaran, the current president of the Kerala Society of Ophthalmic Surgeons. And to his credit, he has been pivotal in investigating a lot of cases of endophthalmitis in our state. Welcome you, sir. I have with me moderators, Dr. Santosh Shanovar and Dr. Manoj Mathur, who will be joining us very shortly. And the eminent panel that we have to discuss this includes Dr. Manoj S., Senior Retina Surgeon at Chaitanya Hospital, Dr. Aditya Reddy from the Geetha Hospitals, Dr. Kiran KR from Comtrust Eye Hospital, Calicut and Talasheri, Dr. Pooja Kandula from Shankara Guntur, Dr. Pradeep Kumar from Center for Sight. To take us through the initial part of the journey in terms of cases, which will provide fodder for our discussion, we have three young and enthusiastic retinal fellows, Dr. Ashwati Muralidharan, Dr. Grishma MG, and Dr. Asla Jahan. So without any further ado, let me start the case presentations first. And it will be a 3-minute case presentation to start up the discussion. And first would be Dr. Ashwati Muralidharan, who will be presenting to us a case where there was excessive manipulation during surgery, which resulted in excessive reaction, and then beyond that. Over to you, Dr. Ashwati. Can you share the presentation?
Gopal, before you start, can I say a few because I have to leave?
Yes, sir. Please do, sir.
I think it is, one of the very important topic for, all of us to understand the importance of inflammation or infection happening after any intraocular surgery, and more so for a cataract, because that is where, or the what we normally talk to the patient that you'll be gaining immediate rehabilitation, and we are doing a refractive cataract surgery, which is the nowadays the fashion of getting through the patients. And if something happens like that where you have a severe inflammation or a hypopyon coming after cataract surgery, it is a setback for not only for the surgeon, not only for the patient, for the entire family and the setup which we are working with. And that necessitates not only investigation of your own setup, the entire hospital, the patient coming in, going out, everything has to be looked into because it can be anything which can cause these type of inflammation. But majorly, culprit goes to a operation theater, because there where we do all these procedures, and always, I think always the blame goes to surgeon only. So surgeon is a responsible person for any outcome. Therefore, he or she should be so careful governing the entire surgical area, because whatever happens, whoever does anything, the blame comes to surgeon only. So that is the importance of a good documentation of patient's counseling, the procedure, the records, examination, everything has to be perfectly recorded. And the importance which we are going to discuss here is the first few days of a surgery, where things can happen. And sometimes I've seen people saying, okay, this is a 10-minute surgery, and you can walk out and go to your office and start working, and next day go for a golf, which is not a very, very, good practice from our side. So I think we have to be very careful how we sound to the patient, because eye surgery, intraocular surgery is simple, but the outcome, if it goes in a different direction, it can be devastating. So we have to be very careful how we frame the entire or practice in this regard. And the information to patient regarding the early signs of endophthalmitis or inflammation, the slightest change in the vision, the slightest, light sensitivity, which is so important, and a pain which is so unusual. Before hypopyon comes, once the hypopyon is there's late presentation of these patients. So that is what I think we should stress here, how to pick up early, these cases so that we can, manage them appropriately and save the vision of these patients. But fortunately, the guidelines are so well designed nowadays from AIOS point of view also. And those guidelines are very, very elaborative to understand how things are being. And as far as AI is concerned, like we do have a various forums to look into these aspects. And if something is happens that we can, fight for the surgeon, the institution also. And Dr. Manoj Mathur will explain later, like what are things we take to help the AIS members in this regard also. Apart from formulation of guidelines, we should also look into the safeguarding the or members of society, which is so important these cases. Sometimes not a fault of ours, it happens because of various reasons, and a lot of medical litigation comes in this direction. So that point should also be looked into. I think both Hemant and Gopal will look into this, and especially Dr. Rajiv, as you said, he's done a lot of investigation in the endophthalmitis cases, and especially for a cluster endophthalmitis, which is the major hit back, and it is the media attention which creates the problem for all of us. I think recently I was reading a news, where few cases lost vision after endophthalmitis. It happens, but it goes into such a bad picture in the media, where the entire hospital gets disrepute. I think we need to look into those aspects, and I think we should sound our members to be very, very careful here. Thank you again. I think, Gopal, sorry to interrupt. You can proceed now.
Thank you very much, sir, for those words of wisdom. I will also like to, like Dr. Hemant Murthy, sir, our other chairperson from a senior retinal surgeon from Bangalore. Sir, can you also speak 1 minute, and then we will go to the cases?
I think Dr. Titial has amply stressed the importance of recognizing this problem, that we all have to, all ophthalmologists have to be aware of it. It's not that only cataract surgeons have it. We all come across. I think we all should be aware. This is a very important topic that we should always debate on and understand what are the needs that we should, or what are the care that we should take during our surgery, post-operative, and how should we guide our patients. I think in all, it's going to be most important that we do it as ethically as possible, try to be true to the patient so that we get the best outcome. Ultimately, everyone is happy once the outcome is good.
Thank you very much, sir. So the number one thing is do not trivialize. Number two is be honest. And number three is act fast. So three things that was told. Now let us go to the cases. Case one is Dr. Ashwati. Over to you. Can you share the presentation?
Yes.
Asla?
Is it not visible?
No, it is not visible. No. Can you share it once again?
Okay, sir.
Lorenzo, click on the share button on the screen.
Yes, it is getting visible. Can you make it full screen? Thank you. Yeah, Ashwati, over to you.
Yes, sir. Good evening. I'll be presenting the first case. So the patient is a 63-year-old male who is a non-case of diabetes mellitus since 10 years, but with good glycemic control. His HbA1c preoperatively was 6.5. He came with a blurring of vision in left eye more than right eye. On ocular examination, the best corrected visual acuity in right eye was 6/18, left eye was 6/24. Anterior segment showed a cataract reading of nuclear sclerosis grade 2 with early posterior subcapsular cataract in right eye. nuclear sclerosis grade 2 to 3 with dense posterior subcapsular cataract in left eye. Dilated fundus evaluation was showing both eye moderate NPDR with clinically significant macular edema. He underwent left eye SICS, which was done by a postgraduate resident. Perioperatively, there was a PC rent, which was initially unnoticed. The IOL was implanted, but then the tilting of the IOL was noticed, following which the lens was explanted, followed by anterior vitrectomy, and AC IOL was placed. The entire surgery took approximately 2 hours. Postoperative day 1, visual acuity in left eye was 6/12. Cornea was mildly edematous, so he was started on topical fluoroquinolone antibiotics 6 times a day and topical steroids Predfort 6 times a day with tapering. There was no systemic antibiotic or steroids which were given. The patient again presented after 5 days with pain, redness, and defective vision in left eye. On examination, the vision had dropped to 3/60. Anterior chamber was showing 4+ cells. Cornea was edematous. There was a 1 millimeter hypopyon with fibrinous reaction. Pupil was dilating. Fundus view was hazy due to the vitreous haze. The B scan showed mild to moderate diffuse echoes, which is suggestive of vitritis. So left eye, intravitreal injection of antibiotics, Cefta and Vanco, was given on the same day. But the next day, vision dropped further to 2/60, even with intensive antibiotic and steroid. So we proceeded with left eye vitrectomy with intravitreal antibiotics. The sample was sent for culture and sensitivity, which he was given early Predfort along with intense moxifloxacin 6 times a day, and homide also was given early. He was also started on oral ciprofloxacin 750 milligrams BD. Even though oral steroids were started due to hyperglycemia, it was deferred after 2 days. Later, on postoperative 1 week, the vision improved to 6/18. Cornea was clear. AC reaction had reduced significantly. And the fundus, again, moderate NPDR with macular edema.
Thank you very much, Dr. Ashwati. You can stop sharing the presentation. So this was to summarize this case. I would say that this patient came with. You can stop sharing. Yeah. So to summarize this case, I would say that this patient was operated. There was excessive manipulation intraoperatively, and it was a long surgery. There were complications which were managed. And I would say that post-operatively, the patient was not optimally treated in terms of reduction of inflammation. There was 6 times of topical steroids only, no systemic steroids or anything like that. But 1 week down the line, this patient presented with more decrease of vision, more reaction, which could be either of the two. It could be either an excessive reaction, which is not properly treated with steroids or other measures, or it could be development of an end-off. I would like to ask Dr. Manoj, sir, what do you think would have happened? Would you err on the side of excessive reaction, or would you err on the side of endophthalmitis when you see the patient initially itself?
I think going by the stormy intraoperative procedures that the patient underwent, I would first think in terms of a severe postoperative inflammation. As you rightly said, the initial postoperative period was not adequately covered with steroids. And if I remember, if the picture also shows something like a cortical matter still in the anterior chamber inferiorly. I don't know whether I could see whether it was just seen the photograph or so. It looks like there's some retained matter there, and that could have incited a strong inflammatory response. So I think that my first impression is that this is a severe postoperative inflammation, which probably I would have stepped up steroids and watched over 1 day. It is true that there is some vitritis there, but we also know that this patient had an anterior vitrectomy, and and so the vitreous was disturbed primarily during surgery, and that could have contributed to some kind of a vitreous reaction, spillover inflammation there. So I would have hiked up the steroids and observed for a day to see how the response, what happens to the eye.
Okay.
And over the next 24 to 48 hours, if I feel that it is worsening in spite of my increasing topical and systemic steroids, I would actually think of injecting. That is one way. The other thing is the patient is a diabetic. This patient is a diabetic. So
Yes.
we know that the diabetics is a state where things can go wrong. So I think that also will weigh heavily on my mind. I'll keep that in mind, and if the glycemic controls are not very, under good control, I would tend to err on the side of infection a little more earlier. Yeah.
Okay. Titiel sir, what do you think should be the optimal management of a patient who had a PC rent and ACIOL? How much would you keep the day one? I mean, on discharge, how much would you keep the topical steroids, topical antibiotics, and would you add systemic steroids?
I think this is a case which requires a definite attention right from the table onwards. The surgeon has to be very careful doing a good vitrectomy so that nothing is in antechamber. And towards the end, intracameral antibiotic is necessary in these cases, 100%. You all know that study from Arvind's, which is proven that patients with PCR and anterior vitrectomy done, the chances of endophthalmitis is at least 3 to 4 folds more than the normal routine cases of phaco. And intracameral antibiotics does significantly decrease the incidence of endophthalmitis in these cases. But yes, once it has done, I think normally I don't give subconjunctival injection in a post-op patient. But these cases where they are going to have a lot of inflammation, would have given a subconjunctival injection, Genta Deca, and if possible, a little bit of atropine also, because ACIOL, everything. And next day, once you see this patient, the intensive steroids should be given. And because nowadays most patients are daycare, we are not seeing them patient inside. Otherwise, in many hospitals, these are a patient may be admitted and intensive steroids should be given topically or sometimes subconjunctivally also. But I would have given a 1 to 2 hour steroid to begin with in these cases. Next day, if the inflammation is so severe, looked into the glow and intraocular pressure. Intraocular pressure may be also be challenging in these cases. There's a corneal edema and pressure recording can be challenging, and glaucoma can always be there in these cases. Systemic steroids normally don't give in a day one because topical I understand that covers very nicely every 1 hour in these cases. But I would have given a systemic antibiotics for these patients as per the norms. Once you have a complicated surgery, a systemic antibiotic is indicated in these cases to safeguard yourself also. Normally, we have a policy now for every surgery, we write a system antibiotics also, just cover up your medical legal aspect also. Though we know that it has no extra added effect on the patient, apart from having a gastroenteritis or gastritis from these patients. But once you have a complicated surgery, may be indicated. And day one, the patient coming up one day back after 48 hours, is the inflammation going on? Yes, you could have thought about doing a good examination if needed, ultrasound for these cases to see anything there, and change the policy in these cases. Steroids, such cases 1 hourly to begin with, and see the patient after 24 hours. If things are under control, they can maybe go to 2 hourly or 4 hourly subsequently. The initial bolus has to be there, which is of high concentration, and as you said, act fast and act in a manner which is controls the inflammation fast.
Thank you very much, sir. One word of caution, though, about the gentamicin in the presence of PC rent and ACIOL. Maybe it may cause macular infarction. That is one fear that we may be
That's
having.
intracameral.
Yeah.
Yeah. Normally, subconjunctival may not be there, but yes, be a little cautious.
Yes. So now 1 week down the line, the vision dropped significantly to 3/60. Reaction increased. Vitreous haze started appearing, and hypopyon appeared. So at this point of time, at 3/60 vision, Are we justified in just giving an injection and waiting for maybe a couple of days, or would the panel be ready for doing a vitrectomy? What do you think, Hemant sir?
No, I think, see, first of all, let's be very clear that, see, in this patient who has had a, stormy intraoperative course, what Dr. Titial mentioned, I would say always keep the patient on close observation. I think the fact that the patient came after 1 week actually is not the way that we should treat intensive steroids and follow up the next day. I think that follow up is more critical. Once you know that this is the course, you should expect that there could be a problem. And that is the key for the whole thing. And once you observe this at 1 week, I think you should start looking at, nowadays we do early vitrectomy. Nowadays, we don't really look at doing intravitreal antibiotics because this is the best way. It's like an abscess, so you drain the abscess. So, principle of general surgery, we follow the same thing. I think it's best that it is treated, because once you do and you get an adequate sample. See, people who just try to do a tap, it's very difficult to do a tap and get an adequate sample. So most of your results are always negative because you don't get an adequate sample. So anyway, when you're going inside to take a sample with a cutter, I think it's best to do a core vitrectomy and then give antibiotics. It does a lot good to the patient, early recovery of the patient, and you don't lose time in treating these patients.
Okay, thank you very much, sir. So let us, for want of time, move to the next case. Dr. Grishma, can you share your presentation? This is a case of a bleb-related end-off, I think, which presented in 1 week's time. Am I right? Grishma, you are muted.
He's muted.
Grishma, you're muted. Can you?
Mute.
Good evening to all. My case was of a
Yeah, now we can hear you.
yes, sir.
Yeah.
My case is that of a 48-year-old gentleman without any comorbidities. He was referred from outside as a case of right eye anti-closure glaucoma. He was already on multiple anti-glaucoma medications. His best corrected visual acuity in the right eye was 6/12. There was iris atrophy and features of iris iridocytosis with posterior subcapsular cataract. Gonioscopy showed narrow angles with fine peripheral anterior synapse. His cup disc ratio was 0.75. Intraocular pressure with all his medications was 42. The fields showed double arcuate field defect. See, there was no macular split associated. So he was diagnosed as a case of progressive iris atrophy with anti-closure glaucoma and posterior subcapsular cataract. He underwent Phacotrab with mitomycin C, 0.4 mg per ml in the right eye. His first post-op day was uneventful with a visual acuity of 6/6, intraocular pressure of 12. So there was no blood manipulation or massage done. There was no remarkable inflammation. Actually, however, on the post-op 10th day, he presented with sudden onset pain and decreased vision for a period of 1 day. His visual acuity in right eye was hand movements close to face. Blood showed a milky white appearance with congestion all around. There was fibrinous exudates in the anterior chamber with 1 mm hypopyon. There was poor view of fundus. However, the red glow was seen and disc and vessels were faintly seen. B-scan was done, which showed vitreous echoes suggestive of vitritis. Hence, we did a recall audit. Actually, we found out that the same day all the cases were fine, but same OT, a cataract surgery case, a single case which was done 1.5 months back by a different surgeon, had hypopyon, and culture and PCR was however negative for that case, and it improved with intravitreal antibiotics. So our patient was started on topical fortified antibiotics, steroids and homide. Systemic IV vancomycin was given. There was a dilemma because we could not apply EBS guidelines because it was a combined case, and whether to consider this as a phlebitis or a phlegb-related endophthalmitis. We were also thinking whether to consider an early vitrectomy because we wanted an aggressive management being a combined case, or to merely go with intravitreal antibiotics because the visual acuity at presentation was handled. We were also thinking whether to consider ACTAC, ACTAC or both, and should we give intravitreal steroids and the role of systemic antibiotics and steroids. So our dictum was to err on the worst scenario for the betterment of the patient. So the day one, the vitreous tab was taken along with intravitreal vancomycin and cephalosporin. But unfortunately, on day 3, the vitreous echoes increased. And the vitreous tab, we had sent the gram stain and KOH was negative. PCR, we had sent PCR, panfungal came negative, but bacterium was positive. Cultures later on came as negative. So day 3, we repeated being a bacterial endophthalmitis. So we, along with intravitreal antibiotics, we gave intravitreal dexamethasone also. And day 5, actually the vitreous echoes reduced. Still we went ahead with an intravitreal vancomycin. The topicals were continued for 1 week, and systemic vancomycin IV we gave for 5 days. And this is a clinical picture after 10 days of third injection. The blood whitened, there was no congestion. The fibrinous X-rays resolved, the hypopyon disappeared, and there was a clear view of fundus. However, in B scan, there was minimal vitreous echoes. Actually, the patient that time had a vision of 6/6 with the IUP of 10. So regarding a combined case, when we encounter an endophthalmitis, our dilemma was whether to go with the patient's symptoms, whether to rely on the phlebitis color, vision, the AC reaction, the view of posterior segment, or medical legally should we actually repeat a TAP or PCR and prove it as negative before discontinuing the interventions. Thank you.
Thank you very much, Dr. Grishma. Here, we do not have any doubt of the diagnosis of endophthalmitis, as the patient had 6/6 vision clear media on day 1. And on 10th day, the patient presented with pain and decrease of vision to hand movements and a significant vitritis. So there's no differentials here. We have only endophthalmitis. Now, since it is a phacotrabeculectomy, we moved towards vitrectomy, even though we could not directly, even if we were to be implementing EVS criteria into this, we would have done a vitrectomy because visual acuity was only hand motions, whereas EVS looked at hand motions at 1 meter to be eligible for a vitrectomy. Dr. Manoj, may I just ask you, what are the usual topical medications that you would give? What are the usual intravitreal injections, which are the antibiotics that you will give? Will you give an antifungal initially, or what would trigger you to give an antifungal initially? And the systemic antibiotics. So topical, intravitreal injection, and systemic antibiotics. What would your take be? For a post-cataract endophthalmitis.
Yeah, for a post-cataract endophthalmitis, I would generally start with a broad spectrum antibiotic like vancomycin, which can cover all the gram-positive, because gram-positive organisms are the commonest cause of endophthalmitis in the post-cataract scenario. And I would also add ceftazidime. So this is my choice of antibiotics. Fortified vancomycin and fortified ceftazidime will be my choice of antibiotics to start with topically. I would not give subconjunctival antibiotics. I do not generally give systemic antibiotics unless we are dealing with an atypical, like in this situation where there's a phaco trap, where there's a lot of scleral surgery also being involved in the primary surgery. In these situations, I would give a systemic antibiotic, but otherwise, I would not give systemic antibiotics in these patients. And intravitreal, my drug of choice would remain vancomycin and ceftazidime primarily. But if I have features of gram-negative endophthalmitis, if at presentation I see a very severe hypopyon with infiltration of the corneal lip or iris inflammatory deposits, and absolutely no view of the fundus, it's features suggestive of a very severe gram-negative endophthalmitis, or like a very fulminant course coming quite early before the 7th day. or before in the first 3 or 4 days, then I would think of adding a better gram-negative agent like imipenem. I think there's some data from LVP which says that no, most of these gram-negative ones are maybe some of them may be resistant to ceftazidime, so I would prefer imipenem. And if it is late post-op endophthalmitis, I would keep 3 or 4 weeks down the lane endophthalmitis. I would think of fungal pathologies. But here the eye may not be so red, and it may be more whitish kind of an inflammation that these patients have. And if I think in terms of a fungal endophthalmitis, I would sometimes give primarily along with the vancomycin and ceftazidime oriconazole. I feel that there's no harm in giving oriconazole if I strongly think from the clinical point of view that I'm dealing with a fungal organism.
Okay, Manoj. So the gist of it is generally you will stick to vancomycin and ceftazidime. But if you have more severe fulminant infection early on, which may signify a gram negative, then you may add an imipenem, a meropenem sort of things. And then only for atypical organisms like phacotrabeculectomy or something like that, you would add a systemic antibiotic. But generally an oral systemic antibiotic like ciprofloxacin with a higher concentration can be easily given to these patients. For vancomycin injections, you may have to admit the patient, and because vancomycin is given intravenously, so you may have to admit the patient. So a clinic who is doing it may not be able to do that probably, right? And in later presentations, like after 3 to 4 weeks, when you are thinking of fungus, then your primary injection may also have voriconazole, right? So any difference in opinion in the panel from what this is, any different thought process? Very rapidly.
The only thing that I would want to add is that there is the role of systemic antibiotics, though controversial. I think we have data from both the ESCRS study as well as from other studies. Even the Royal College guidelines, they do not advocate systemic antibiotics generally in the post-cataract endophthalmitis scenario.
Okay.
They feel that even the EVS did not find the EVS a different reason. They probably gave a different kind of antibiotics. They covered more gram negative, whereas the spectrum was gram positive, and therefore didn't work in their situation. But I think from the literature, it looks like we are not very sure whether. But then we want to be safe.
Yes.
So legally, we would want to be safe.
Just like Tijal sir was telling that even after routine cataract surgery, if there is some problem, then you would give a systemic antibiotic just to be legally safe. Yeah. Yeah. Hemant Murthy sir and Aditya had just unmuted. Hemant Murthy sir.
Yeah, I mean, I think I agree with all what was been said. I think the LV Prasad, study on endophthalmitis has amply shown that, you can, instead of ceftazidime, you could start on, because I think this is the spectrum of infection that we see in India these days. Fortunately for us, most of the early endophthalmitis or the endophthalmitis that we see is of a low virulence, so we are able to get away with the treatment that we do. I think whenever there is a more severe inflammation, I think it's also good to add on intravitreal steroid, because ultimately you want to avoid the destructive power of the organism, because I think the toxicity is what creates more damage to the retina than the infection per se. So I think in a fulminant infection, you try to add on the steroid intravitreally.
So if the patient is presenting on the first week following surgery, probably your possibilities of fungus are low, immunocompetent patient, no string of pearls, no satellite lesions, no retinitis, which are focal, like that, then fungus is away, then probably you will also add intravitreal steroid.
Intravitreal steroid, because in early endophthalmitis, it's very rare to get fungal to go up to that level. So I would always expect fungal endophthalmitis to present much later.
Sure.
It needs some time to grow, so it's never so rapid as a bacterial endophthalmitis.
Sure, sure. Aditya, you had some point? Very rapidly, then we will go to the next case where Asla, you can share your presentation.
Oral ciprofloxacin 750 milligram BID is, I'm using the oral ciprofloxacin. What the studies I went through says that is oral ciprofloxacin when given for 3 days, it increases the vitreous concentration comes up to 21 micrograms per milliliter. It also shows it also helps in countering the virulent organisms. So any people anyone using
So
We
I
are
think
also
what
using
you
oral
no,
750 milligram. Yeah.
and I think what you're mentioning is right. It's they have done this. The problem in is like this, that most of the studies have said that that is not the key to your treatment. Actually, systemic antibiotics is not the way to go about. But I think for legal purposes, you have to put the patient on systemic antibiotic. I agree that there's been studies which have been done which show that the MIC in is reached in when you give orally, and especially once there is a breach, like in this patient who has had a trab in addition to phaco. I think it amply demonstrates there is an adequate concentration. I think it's okay to give it. It's probably a easier way to keep yourself safe. I think we do all measures that is necessary. Studies are secondary. I think we take all measures to ensure that we get a good outcome.
Correct. All possible measures covered.
One word
So,
of caution will be on the use of moxifloxacin, because we have been very rampant in the use of moxifloxacin. So using it as an agent in the post endophthalmitis scenario may not be correct, because we may be having resistance. That's one. We do not have oral moxifloxacin, but oral moxifloxacin is known to cause severe uveitis by itself. So I think that also is like, orally we don't have it here, because I happened to see a patient who came from the Gulf, who had undergone a surgery and came back to us 10 days after with a severe uveitis, hypopyon uveitis, and we initially thought of endophthalmitis. But within 2 days, the patient developed a very similar picture in the other eye. And that's when we went into the drug history, and then we realized patient was on oral moxifloxacin. So I think that is something that we need to remove.
okay. For want of time, let us move to Dr. Asla, the case presentation on severe endophthalmitis. Yeah.
Good evening, everyone. This is a case of 53-year-old male with no non-comorbidities and progressive blurring of vision in left eye for 6 months. On examination, right eye was pseudophakic with posterior capsular opacification and left eye with nuclear sclerosis grade 3 and posterior subcapsular cataract. His best corrected visual acuity in right eye was 636 and left eye was 624. Fundus both eyes showed retinitis pigmentosa. He underwent a small incision cataract surgery. It was an uneventful surgery. Time taken for the surgery was less than 20 minutes. So, post-operatively, he was treated with moxifloxacin eye drops 4 times a day and Predfort 6 times a day. On post-operative day 1, his vision in left eye was 618 with clear cornea and minimal anterior chamber reaction. He presented after 1 week with pain, redness, and defective vision in left eye. His visual acuity in left eye was hand movements and projection of rays were accurate. Cornea was edematous with anterior chamber reaction of 4 plus cells and 1 mm hypopyon and fibrinous reaction and membrane covering the pupil. Though the pupil was dilating to 5 to 6 millimeters, the fundus view was poor. So on B scan, there were multiple dot echoes in the vitreous cavity with of moderate intensity and retinocoroidal scleral thickness of 1.5 millimeters, suggestive of vitritis. So, as there was intense reaction, he was treated with vitrectomy and intravitreal antibiotics, that is ceftazidime and vancomycin. And he was post-operatively treated with oral ciprofloxacin 750 milligram twice a day and tapering doses of Vislon. And Predfort was given 1 hourly. Moxifloxacin was also given 1 hourly, and homatropin was given 2 hourly. His gram stain and chaos mount came negative, and culture was also negative. On 1 week follow-up, he had a vision of 612 and fundus showed retinitis pigmentosa changes with the pigment epithelial changes at the macula.
Okay, thank you very much, Asla. So here again, the diagnosis of endophthalmitis is not at all in question. The patient presented probably this best visual acuity in the presence of retinitis pigmentosa and those RP changes in the macula, maybe 6/12, 6/9, and he regained good vision, followed by tuck reduction of vision to hand movements with pain and all those symptoms. So diagnosis is not in question. And the first two cases we have discussed about the antibiotics, the choice of antibiotics, the inflammatory cover, all these things we have discussed. Now here in this case, let us discuss about the timing of vitrectomy and the technique of vitrectomy. How early would you want to go in for vitrectomy? Number one, when the presence of hand motion vision. Should you wait with 1 day of intravitreal antibiotics before vitrectomy? Many of the times the patient may land up in the night and your surgical instruments or the theater may not be ready at that point of time. Or in the day when the patient lands up, the day will be filled with clean surgeries and you may be able to do it later on only. So would you want to give an intravitreal antibiotic first and later on take up this patient for vitrectomy when the theater is ready? Or that is point number one. And point number two would be, how would you do? Would you do just a core vitrectomy with intravitreal antibiotics, or would you want to do a more complete vitrectomy? Let us start with Dr. Kiran.
Sure.
What is your opinion?
Yeah, we have to also consider a lot of practical aspect, like you said, the other clean cases going on in the OT and the availability of the OT and everything. But still, I think the concern should be the vision, how much the presenting vision is. If it is very poor, I think most of the cases we'll opt for vitrectomy. But like in such a practical situation comes, we can give an injection and then maybe don't delay the vitrectomy too late. But the focus should be that the early vitrectomy should be done. And about the core vitrectomy and the complete vitrectomy, it depends basically on the visibility. Many of these patients, their cornea might be bad. They might have a lot of membranes and pigments and everything stuck to the eye hole. So the visibility is usually very poor. So in such a case, my aim would be to first get the sample. First, you try to get the vitreous sample, then do a core vitrectomy, because in the poor visibility, there's more chance of us inducing an iatrogenic break and progressing to an RD. So to do less harm, so do a core vitrectomy and inject, and later, the visibility improves. Maybe we can later take up one more time and do a more thorough vitrectomy if the patient is not responding. But and along with that, like we'll have to give a intravitreal injection along with the vitrectomy.
Well explained, Kiran. I would also want the senior people in the panel to just comment on, some patients coming late in the night or in the daytime when the theater is filled with clean patients. What would be your advice to the ophthalmologists who are hearing this? Hemant sir and Rajiv Sukumaran sir. Rajiv sir.
Dr. Rajiv, you can go.
No. Can you come to the question again? I was absent-minded sitting here. Oh.
Yeah, that's okay. Hemant sir, then you can do. See, basically the thing is, when we are, sometimes these patients of endophthalmitis come late in the night or in the morning when the theater is full-fledged. Maybe there are 10 surgeries today. And in the morning when the patient lands up, we have to, if we are taking the endophthalmitis case for vitrectomy there, then it becomes a little bit of a mess because that theater now has to undergo, about 10 patients clean surgery has to be undergone. So what would be your thought process in such a situation? If you have to do it in your own setup, otherwise you would have to refer this patient to
the patient.
Yeah.
And, as you said, intravitreal injection will be ideal at this situation. Give that and wait for the 10 cases to get over, and by then you will get some response. And in the meantime, what I do is give intensive steroid drops, so that we can see within hours you can change, make the difference, that you can come to a conclusion that it is endophthalmitis.
Okay.
Then you can take it up.
Yeah. Now, see, the problem is we are all talking because we are all retinal surgeons. So it's very easy for us to say that we do vitrectomy. But I imagine that majority of our people are anterior segment surgeons, and they won't have a support team for them to really initiate a retinal procedure. So the good choice is to immediately give an intravitreal antibiotic, and then refer the patient to a place where vitrectomy is done, so that we don't lose time. I think there has been situations wherein patients were referred from a primary ophthalmologist elsewhere in different places, and the time the patient reaches us is about 2 or 3 days after they have been diagnosed, which I feel is we have already missed the time that it should have been treated appropriately. So this is known. I think all surgeons now can do an intravitreal injection very safely. I think it's time that we say, please treat as soon as you recognize it. Don't wait that till the person goes to the retinal surgeon.
Very correct, sir. So a lot of studies have come out where they show that the final prognosis of the patient is start of symptoms to the time that it takes for the first intravitreal injection. So if that is reduced and reduced and reduced, obviously the prognosis can be much better. So again, thank you very much, Asla, for bringing that case up. Now let us go to the keynote presentation by Dr. Rajiv, sir. So Dr. Rajiv will be talking to us on investigating not the case, but the entire scenario, the ecosystem when there is an end-off. Because one end-off may be a tip of the iceberg, or maybe this particular surgeon or this particular hospital may have had 3 end-offs over the last 4 months. So it may be a bomb which is waiting to be burst. And let us see how we are going to diffuse it. Dr. Rajiv Sukumaran, please.
Thank you, Dr. Gopal, for this wonderful opportunity. Okay. So actually, I give talks on cluster endophthalmitis, but Dr. Gopal wanted me to stick on to today's topic of an isolated endophthalmitis. How do you investigate? So I'm going to do it as stepwise approach with checklist and corrective measures, but I'll give enough place for discussion so that if I cover everything, then there will not be questions. So I'll touch everywhere, then we'll go in for discussion. Endophthalmitis is rare but devastating complication. It's a nightmare, actually. Isolated case often dismissed as bad luck. This is a mistake. Every case, a system failure until proven otherwise. So the goal is to identify the root cause, prevent recurrence, and ensure medical legal safety. Because these days, everything, I have investigated a few cases of endophthalmitis. Most of them are going for medical legal problems. So when you see a case like this in your OP, maybe a week later or after a cataract surgery, do not panic. First thing is be bold and alert your team that such a thing has happened. So alert a team, be calm, don't show your emotions to the patient. That word should not come from you. Just relax and communicate with the patient. Then in my investigation, CCTV has helped me a lot in investigating, especially in the OT. See how long the case was taken to do, whether consumables were exchanged, whether the tray setting was done, and all the handling of consumables. Otherwise, the number of people in the theater, and even in the scrub area, if you have a CCTV, it will show you how good your scrubbing, your sterilization place. If you have a CCTV, you'll know what is happening there. So in my investigation, CCTV has given me a lot of clues, just like in any other crime. This has given me a lot of clues in this. So type of endophthalmitis, acute, intraoperative, it is contamination. Delayed, it can be pyacnia or fungi, fulminant, virulent organism. Isolated versus cluster cases. These are the clues we get. First step is confirm your diagnosis, either by clinical diagnosis or vitreous tab, AH mount, or whatever it is. You confirm that it is endophthalmitis and then proceed to investigate. Culture, take for culture before you give antibiotics, whether it is oral, topical, whatever it is. First thing is take for culture. Otherwise, it's going to be negative. Ensure proper lab support. This is very, very important because our samples are very little and proper lab support should be there to get a result. So immediately transport in appropriate media. Availability of gram stain, KH mount, and culture, both aerobic anaerobic and fungal, access to advanced tests like PCR if culture negative. All these things should be there and should be in good terms and a reliable lab for you to depend on. Postoperative endophthalmitis, we've got so many organisms. The most common is the gram-positive bacteria, that too Coagulase negative staphylococci, and other acute fulminant maybe streptococcus species or enterococcus species. And postoperative endophthalmitis may be due to gram-negative organism, Pseudomonas, are delayed due to P. acne, fungi, aspergillus, endogenous. Endogenous endophthalmitis is Klebsiella is most common, very common in Asia, especially during people with diabetes, Candida species and others. This table will give you an idea from where this infection has occurred. If it is gram-positive, usually occurs between 1 to 4 days or within a week. So usually it is from the lid flora or some breach in the body. That what we are dealing today may be gram-positive cases because it has presented within the first week. Gram-negative will be acute fulminant within hours or 1 or 2 days. It is usually the fluid contamination or endogenous diabetic. Delayed may be delayed may be due to the propionibacterium acne, or it will be months or weeks later it gets intraoperatively seeded. Fungal candida or the environmental source, usually the air contamination causes the fungal. So review other cases you have done that day. If they have not come for review, call them, ask for symptoms, or ask them to report the cases done on that day, the previous day, and the next day also, if they have not come for review. But don't tell them that you have a complication, so we are calling you for earlier. Just politely inquire about the symptoms, their vision, all those things, and communicate with them. Then communicate properly with the patient. Be very polite to them. Tell them that there's something happened, but we can take care of all this. And the bystanders. Take them into confidence and assure them that the best will be done for them. That is very, very important as far as when you're treating an endophthalmitis. Timeline reconstruction is the key in diagnosing where the source of infection has occurred. Track preoperative, intraoperative, and postoperative. Identify which OT was done in a multi-specialty center where you have many theaters, the staff who was there, the consumables, maintain traceable records. Everything should be recorded. Everything should be recorded. Track preoperative. Review patient evaluation records, whether systemic status, diabetes control, immunosuppression. Check for ocular surface issues like blepharitis, conjunctivitis, dacryocystitis. Verify preoperative medication, whether they used it properly. Ensure fitness for surgery. Any risk factors addressed beforehand. Any septic foci or caries tooth or an infection in the leg or anywhere in the body should be looked for. And how do you do it? Mandatory preoperative ocular evaluation is a must. Not just look at the cataract and say post for surgery. If there is blepharitis, treat it. If there is dacryocystitis, do DCR before elective surgery. Optimize blood sugar before. There is AO's guidelines for it, which you can follow. The preoperative protocol, povidone iodine is mandatory. Minimum 3 minutes contact time is needed. Proper draping and lash isolation is very, very, very important. Common error is applied but not waited. You just put a betadine and then straight away do surgery because you've got a big list. Should not do that. You have to wait for at least 3 minutes, for it to act. The corrective action for this is strict povidone iodine contact time protocol. The OT nurse should have a checklist and enforce it. Only then it can be. All this in CCTV, you can see how quickly you put the povidone iodine and how quickly you started. All this will help you in coming to a conclusion where you went wrong. Povidone iodine, there is no excuse at all. Intraoperative OT discipline is very, very important. Air quality, of course, now we have the HEPA filter, which will give you filtered air, which is ideal for ophthalmic setup. Then hand hygiene, scrub, gowning, changes. All this is there. I'm coming to the gown and the glove. It is, as per norm, you have to change for every case, but we don't do it. We change the glove and go. But ideally, every case is the first case. Not that the third case gets a different attention. The first case gets a different attention. Then the sterilization logs. The autoclave should be monitored. The sterilization process should be monitored, checked, doubly checked. You should have 2 or 3 indicators, one within the instruments, one outside the packing, and the entire set, and everything should be labeled, signed, and documented. That is, all the indicators should be preserved. Check consumable batches, whether they are expiry date, everything should be there, and the packing, whether it is any breach in the packing is there, should be checked. Sequence of surgery, duration. As you were discussing, in the prolonged surgery, the chances of endophthalmitis is high, and the sequence, the 10th case is more prone for endophthalmitis in a small theater where there is no centralized AC or the lamellar flow. And clear corneal incision versus scleral tunnel. The incidence of endophthalmitis is slightly higher with clear corneal compared to scleral tunnel. Then assess surgical complication, PCR, and intracameral injection is a must in cases with PCR. In fact, it has been documented that routinely any intraocular surgery, intracameral antibiotic should be given. And the number of OT tables, only one table should be there in one OT. Number of persons in the OT, that is maximum 5 to 6 in a ophthalmic theater. Health of the OT personnel, person with fever, cough, or any other ailment should not be allowed to assist or do the surgery. So the ideal OT standard is a HEPA filter that covers about 99.97 efficiency with 0.3 micron. Positive pressure should be there. No air should come from outside to inside. Only through the air conditioning system, the air should enter the OT. Should be about 15 to 20 air changes per hour. Lamellar airflow preferred for high volume centers. Intracameral antibiotic is shown that 5 times reduction in endophthalmitis rate. This is a landmark thing, and now the advocate must be administered at the end of every intraocular case as standard policy. So we'll see some of the mistakes we make in our theater. Using mobile, digging ear, and this is a culture from a mobile. Sorry, Gopal, for using your visuals. The indifferent attitude, wearing street clothes in the OT. And look at this in a camp. You just imagine the risk these patients are taking in getting their eyes operated in the camp. And they are wearing street clothes and opening doors in between, not wearing the mask properly, and opening the door with the gloved hand. It's all going to contaminate the environment. It's the best way is to open, somebody else open and you enter, or you use your back and open. And having eatables in the theater should be strictly banned. And going to the toilet with your OT dress, all this is going to add to your risk. So I'm going to show you basically where all you're supposed to take and how to take cultures from theater when there is a case of endophthalmitis. Or as a routine, this has to be done. One is from the flow, then label it immediately. Then from the OT table, then from the wall, then from the AC. And this one shows the open plate method, which tells you the quality of the air. So what is this open plate method is blood agar is kept, and make sure that lid is kept down, facing down, not up. And it is kept open with the AC on, air conditioning should be on for about 20 to 30 minutes with the door closed with no traffic inside. After that, close it immediately and send it for culture. Depending on the number of colonies, you'll get an idea what the air quality in your theater. Then hand hygiene. It's very, very important that you follow all these steps described in European norm 1500. That is interdigital space, the thumb, knuckle, the tip of the finger, the wrist, and you should spend at least 3 minutes. So only then the povidone iodine will work as an bactericidal agent. So rinse it properly. Don't hesitate. Have a CCTV in your scrub area also. So this is a careless way of doing it. This is not the proper way of doing it. And using stored water. I've seen in theaters where they use this water from the bucket, which is being used for scrubbing. Look at the mask with the hair, and he's putting his hand down so that these are the mistakes we do even now. And yet another mistake, what I've seen now is mixing betadine with soap. This soap cake is being used in many theaters I went, but still, see, look at that, what all chances of contamination is there. All this, and the scrub brush should not be used on the skin because it's a nail brush. Only for the nail it has to be used. And see, she's wearing a ring also. All those things is what is going to happen. Finally, when you do everything properly and when you come, look at that, the drape is, and you hold it like this. It's going to be disaster if you, all these things you can pick it up in. And this one, as yet another I wanted to tell you is, dropping instrument in the surgical area. See, I've just to demonstrate that, I put powder on top of the cover. What is happening to that powder? It is falling. The same thing is going to happen with any dirt or a bacteria, what is on top of it. So whenever you are handing over an instrument to the staff, it should be outside the surgical field and the scrub nurse should pick it up. That is what I wanted to demonstrate in this. So this is the way it has to be done. And make sure that your sterilization process, the cleaning process, everything is perfect and everything is documented. So I'm not going into details of this now. And this one helps you in preventing endophthalmitis to about 99.9%. That is, have one set for one case. Pack it up separately. Don't mix the instruments. Don't use instrument used for another patient for any purpose, any consumables, anything, do not reuse. In my experience, where there was endophthalmitis, I found that they are using, sharing viscoelastic from between patients. That is ridiculous. So this is one thing is take home messages, one set for one patient. Consider every patient as the first patient. Don't keep mixing up everything. So, and check your autoclave machine regularly. This is the Bowdic test, which shows the standard of your working capacity of your autoclave, and it has to be done in an empty cycle every day before your standard autoclaving. And all these indicators, the biological indicators, the class 5 indicators should be used regularly. And consumables audit should be there. IOL, expiry date, the packing, any breach in the packing, viscoelastic, BSS, drapes. Drapes is very, very important that it should stick properly and isolate the lid from the eye so that any infection from the lid margin is, and the lashes should be isolated. Reuse of disposables and sharing is the culprit in most of my cases, what I have investigated. So IOL, batch, lot, and trace for clustering, sterility, packing integrity, any recalls or complaints from any other member in our society or anything that you get, be very careful. Handling contamination during loading. When you're loading the intraocular lens, it can get contaminated. BSS, bottle integrity, seal intact, any sediments in it, contamination risk, shared bottle between cases. That also should be, batch tracking has to be done. Viscoelastic, batch and expiry, single use versus reuse. Never reuse it. proper storage condition, any similar cases with same batch. Post-operative factors is wound, check for wound integrity. Wound leak is one of the reasons for endophthalmitis. Ensure proper antibiotic use. Educate patient on hygiene because that is very, very important. Tell them how frequently you have to use the drops and how to use the drop and how hygienic you have to be. Use of soap and water, wash your hands and use the antibiotics. And step 7 is microbiological, gram positive. It's usually from the lid flora. Gram negative is the fluid contamination. Fungal, it's environmental, the air contamination. So the root cause analysis, identify failure point, was protocol followed, implement corrective systems. So I'm using this fishbone, what is it called? Ophthalmic fishbone. It's called the Ishiva fishbone method. We have 6 criteria. You can put it down here. The patient, the commensal flora, blepharitis, immunosuppression, equipment, the phaco machine, tubing contamination, defective autoclave, or the OT protocols if it is not followed properly, whether flash sterilization was used regularly, missing biological indicators, preoperative povidone skipped, and staff, the discipline, the no-touch technique failures and technique theater traffic, environment, just like the air quality, airborne, concurrent nearby construction or a contamination, viscoelastic, the intracameral dyes. And there have been cases where Pseudomonas has been cultured from povidone in one case. So this final chart will help you give a strong lineup for you to investigate from where this problem has occurred. So the red flags are the same OT, same day cases, same IOL or batch or repeat surgeon cases. So this is called the alert gauge. It's called the Poisson alert gauge. If the number of case is less than 1 in 100 or 2 cases in 600, you have to heighten your vigilance, standard review of your theater protocols, preventive measures. If it is more than 1 case in 75 or 2 cases in 300 to 500, you should review, do only emergency cases, all other elective cases you should stop. Red alert is more than 3 or more cases. Close down your theater, walk up again, check everything before you restart your theater. So prevention, povidone-iodine is key. No compromise on sterilization. Strict OT discipline. Use checklists. WHO checklist is very important also. So medico-legally, documentation is critical. Record antisepsis and batch details. If not documented, it is taken as not done. So for example, if you're seeing endophthalmitis in your OP, and if you're going to install antibiotic or steroid hourly, every hour you record it. If you discuss with somebody, vitreoretinal surgeon, you're a cataract surgeon, record that, discussed with so-and-so, what has to be done. And everything, minute by minute, you record it because that is what is going to save you in the court of law. So conclusion, every case has a cause, focus on system improvement, prevent next case. Thank you.
Thank you very much, Rajiv sir, for that excellent run through of each of the steps in preventing further end-offs. So thank you very much. I think that is a very complete presentation, and I would like to rewind it again and go through
your
the
visuals were there.
Yeah, it's on YouTube. So I think anybody who is seeing it, please make sure that if you want to, everybody is going to get an end-off one time or the other. All of us have got our own end-offs. So whenever an end-off happens, it's up to us as clinicians to investigate that particular case and manage that particular case. That is why we are all joined together. But how to improve the system to prevent the next case is something which is very, very important. And that is exactly what the last 20 minutes we heard. Any further thing to add, Hemant Murthy sir, Manoj sir, anybody in the panel? Anything
excellent talk. I would say excellent talk. You have shown some examples which always occur in the OT. I mean, we have to keep I think this should be an ongoing process. I think we have to remind our staff of all these mistakes that are commonly done repeatedly. It's like, if you tell them once, for a few days, everything goes on as scheduled, but slowly it deteriorates. The only one thing that I think we also used to have a camera in the OT, but the NABH assessors came and said it is a violation of privacy, patient privacy. You cannot have the camera in the OT. So they asked us to remove the camera in the OT. I still have it in my sterilization room and the scrub area, but in the OT we had to remove it. Unfortunately, they refused to accept that. The other thing is, whenever we have a problem, first thing is, I think you should also audit your entire thing. Just go through the whole thing before we consider it safe for us. If it is one case, generally it's not something that is, you need not have to shut down the OT per se, but you need to understand where the mistake has occurred, and that should be corrected. I think we should always, try to keep revising our OT protocol, see that all this is done. I think documentation, which you rightly said, is most important. If you don't document, it is not done. It's as simple as that, which I think all courts also take that if you don't have documents, it's not acceptable. So very
Thank you.
nice, very well said.
Thank you.
Thank you very much, sir. Manoj, you wanted to say something? You are unmuted.
I think specific. I think Rajesh sir has covered it all. The only thing that I wanted to add is that end of surgery is a very rare situation in most of our setups. So we should have, even when you do in a normal course of events, we should have a recall system, just to randomly do a recall system, just to see how efficient our system is and how efficient our documentation process is. As part of NABH and JCA accreditation, all I think most hospitals have it now. But it's a good practice to keep doing it so that we understand the gaps and try and rectify it. And other thing is the number of cases. The one thing that is like there's, the fast surgeons. We have a lot of fast surgeons amongst us. Who can perform who can perform one day 65, 70 cases in a day. And I don't know how because of the AOS task force has very clearly said that the number of cases should be limited. It should be 25 cases over 6 hours.
Yeah, okay.
Or 6 hours. That's a criteria that they have set. I think the same thing has been raised by other bodies also, the Royal College Guidelines, the ESCRS. So I think that is where now I think in India we may have an issue. I mean, whether we can put that into practice because the good surgeons, fortunately, are fast surgeons, and therefore, I mean, but I think when things go fast, you may be fast, you may be good as a surgeon, you may be good in your activities, but your support staff there may be a problem keeping up with your pace, and there is chances of errors happening. So I think that is also something that has to be kept in mind.
That's a point, a very important point, because the support staff may not be able to provide the quality of sterility of what you want. Okay, thank you very much. So let us over the next hour or so discuss a little deeper into some aspects of prevention, identification, early identification, management, and prognostication of cases of endophthalmitis. We will have a short panel discussion. I would basically, let's first start with systemic conditions like diabetes, a very common condition. Now, if you look at cataract surgery, about 50 or 60% of cataract surgery patients are diabetics. So, Dr. Pooja, what do you think a 200, a 300, a 400 blood sugars on the day of surgery or just before the day of surgery, how would you plan to counsel these patients with blood sugars of 200, 300 or 400? Would you consider acute blood sugar control and then operate on the same day, or do you want the patients to come back on another day to do the surgery? Because many of these patients, bystanders, would be flying in from many places and they would have taken the leave for that particular surgery. A lot of such practical problems are there. Yeah, Pooja.
Is that
Dr. Pooja? Yeah, can Kiran take the question?
Yeah, sir. I'm there.
Yeah, you are not visible. You're not visible.
Yeah, so 1/6. Sorry for that.
Yeah.
Oh, is that okay, sir? Yeah.
Yeah, sure. Please
So
continue.
when the patient comes with when the patient has depending on the GRPS level, maybe we can take the call, sir. If the patient is having very high sugar levels, say 400, or definitely we should be deferring the case. 200, maybe we can proceed with the surgery. Less than 200 or 200, maybe we can proceed with the surgery, sir.
Okay.
And definitely, if any systemic infections or any condition, definitely would ask for a physician clearance for the procedure.
Yeah.
Active infection, definitely no.
Yeah. So 400 is your cutoff for deferring the surgery. 300 is not your cutoff. But generally, we should ask the patient for legal protection also. We've been talking about legal protection as well. Generally, we should have a blood sugar levels below 200 or so that we can proceed. May not be on the day of surgery. The day of surgery, usually the patients get tensed, and so the sugars can go high. And 300
Yes.
is one area where you can probably add one or two anti-hypoglycemics. Hypoglycemics, and reduce the blood sugars to a point of somewhere around 200, where you can continue with the surgery. What do you think
Yes,
about
sir.
hemoglobin A1C and its control, Kiran? Somebody comes with 10. Would you defer cataract surgery, or would you want to, still continue with the cataract surgery? What do you think? 10.
Yes.
Hemoglobin A1C.
So, yeah, my decision won't be, taken just based on the HbA1c level alone. Suppose a patient comes with 200, you are in a doubt whether to take him or not. But always consider the HbA1c level also. If they've already done it, I'll just see if I feel that their control is fairly bad, and I don't think cataract surgery is an emergency surgery. So, if at all the patient goes in the end of, later the question will be why we've done the surgery when the sugars are so high. So if it is the sugars are borderline, I'll always consider the HbA1c level. If it is fairly controlled, I think probably around 200 we can, I mean, thinking from the patient side, maybe we can do it. But anything more than 200, I think suppose if the HbA1c level is also very high, I think we should always defer the surgery and, get a proper control, bring the HbA1c down, and, the sugars down.
Okay, so there are no current guidelines of cutoffs or anything like that, and it is better not to talk about cutoff guidelines, because that may end up in a lot of other problems later on legally.
Yeah, I understand.
So, but
Gopal,
as you
can
said,
I,
please,
because
please.
AIOS has got guidelines. Should
Yeah.
be less than 200 on the day of
200.
surgery. It doesn't mention about HbA1c. AIOS guidelines says it's 200.
Yeah, as Rajesh said, I think the AH task force has come out with some guidelines. I mean, yeah, these are guidelines. I mean, they're not that we have to follow them.
Strictly.
Guidelines, they said fasting sugar less than 140 and random sugar of less than 200 and HbA1c value 8.5. So that's a cutoff which they said, and I think this is something they've borrowed this mostly from the Royal College guidelines and AO guidelines, where it is similar. But having said that, no, we may because like this is important because in private practice, no, we are looking at doing more cataract cases because that adds to our the way we run the hospital. So we are most practitioners are under pressure to do early cataracts and sometimes not look at these values. So I think it is important because once we have an end off. We can use these guidelines. Now, in case there is a medical legal case, now we can use these guidelines and say that okay, on the basis of this, everything is documented, and an informed consent is got from the patient in case it's borderline, and then you decide to do it, and then we are in safe hands.
Sir,
Yeah.
Sir, actually, there is a referred case where the RBS was 185. It's an end of case. RBS was 185, HbA1c is 7.2, and all these parameters were normal. But this patient has urine sugars 3 plus, and ended up in endophthalmitis. When we questioned back, he told he had history of burning micturition.
Okay.
And the organism isolated was E. coli. So I think we should also include a urine examination
Yeah.
in
So
roots.
any infection for that matter, be it skin infection, foot infection. Last week only, I saw one patient who was suspected to be endophthalmitis. I gave an intravitreal injection. Actually, on the tape, I saw that the foot had an infection. So his big toe was covered with a bandage. So that is very important. So let us also talk about some of the other systemic infections which may actually, infections or problems which may actually influence it. One is hypertension. Very high blood pressure prior to surgery definitely increases the chance of expulsive chronic renal failure. If the patient is on immunosuppression like corticosteroid therapy or other immunosuppression, so all these can increase the chance of infections. Now let us move to the preoperative care. So do you do syringing in cases? Dr. Pratik, how would you look at the lids? Because most cases of endophthalmitis are blamed on the resident flora of the ocular surface. And lids play a very important role in worsening this ocular flora. So how would you evaluate the lids? Do syringing? Do you give antibiotic lavage or something like that? Or do you just look at regurgitation? What is your thought process, Dr. Pratik?
Am I audible now?
Yes, yes.
Yeah. So routinely, I'm not doing a syringing. Most of the patients, I'm doing a rhoplastist to rule out a frank regurgitation of mucopurulent material. However, I pay an extra attention whether the patient is having meibomian gland disease or a lot of active blepharitis at that point of time. From two perspectives. First is a nidus infection. Secondly, post-operative discomfort if we miss this pre-operatively. Also, the hygiene is quite poor in the belt I am serving right now. So that is one factor that I look into. But yes, if the patient has a frank discharge, then I defer the surgery. Otherwise, I'll give the patient to an oculoplastic surgeon for an opinion.
Okay, so if there's frank discharge or a purulent discharge or something like that, obviously the patient has to go through a DCR, and then we will wait for some time for everything to settle down, and then only we will move in for surgery. Anything else? Anybody endorsing scrubs to the lid margins before surgery, or swabbing the lid margins?
No, sir.
Do you
If
cut the lashes? What
No,
is your
if
thought
there's
process on that?
active blepharitis, I'm treating it first with Betadine, but not planning a surgery. Cutting of lashes I avoid because that can actually express a lot of secretions in the perioperative period. Rather, it is better to properly apply the steady drape while we are operating so that the lashes are covered well and there's no excessive pressures on the glands to increase the secretions.
All right. All right. So one more question that we have to ask in lids is, do you perform, the lash cutting before surgery?
No, sir.
There's no all of that. But make sure that the steri drape or the opsite or whatever you are using covers the upper lid upper lashes quite well. The lower lashes are usually not in the picture, but the upper lashes are definitely in the picture. And blepharitis, meibomitis, definitely we need to treat them. All right.
Gopal, I'd like to add a point.
Sure.
I think everybody has conveyed that Roplas is enough. I mean, that's a very important take-home message. But iOS task force are also given us some indications when you do syringing. They have mentioned 3 or 4 situations when you should do a syringing, and this is like when somebody has undergone a lacrimal sac surgery. Then in these situations you should do a syringing when there is some unexplained epiphora and some suspicion of dacrocystitis, and then these are some situations where they have said, but this should not be done on the day of surgery. That's the only thing that they have mentioned, that it should be done a few days before surgery to cross check whether there's any sign of infection.
Okay. Rajiv sir, what is your take on conjunctival swabs? Some people say we will take conjunctival swabs in one-night patients. Some people say I would take conjunctival swab in all patients. Whether there is, if there is discharge, I will take What is your take on conjunctival swabs?
Actually, there's no study saying that conjunctival swab really helps in preventing endophthalmitis, because most of the time, you get the commensals grown. Even otherwise, Without culture also, it is going to be there. It's your pre-operative preparation, which is very important, and the use of povidone iodine is important. So this culture doesn't make any, if you culture 10 or 100 cataract cases pre-operatively, about 90 will have some growth in it. So there's no point in doing that and then postponing the case. And it's, so you do your pre-op preparation, that povidone iodine for 3 minutes. It kills about 99.9% of the flora in your conjunctival sac. So
No,
there's no need for that unless it's a very chronic conjunctivitis which you want to treat it and then do the cataract surgery. You want to isolate the organism. That case, for example, in canaliculitis and all, chronic infection, there you can do a canaliculoplasty and get those things out and culture them. Actinomyces and all will be there. All those things. Then you're justified in doing a culture. Otherwise, routinely it is not done.
Yeah,
No
I think
use doing
I
it.
remember my days now when we used to do routine culture, and I used to find that it's ridiculous because we used to never have anything. So all the time we used to have a negative report. So I used to say, what is the whole point in doing this? Because it doesn't really matter on why we are doing it. It used to be followed as a protocol, but I think now they have changed. I think everything has stopped. So it used to be done, which was actually had no evidence that it's going to help the patient in any way.
Sure.
Yeah,
Yeah.
but sir, but in a one-night situation, a one-night patient, I mean, in practice, though we know that from the studies, the weight of studies that this is not useful. When we encounter a one-night patient or like where there is a history of some diagnosis.
Conjunctivitis itself in the other eye.
Then it's fine. Then it's
Or
fine.
end of submittation, yeah, exactly. End of submittation, other eye. No, yeah, it's. I think there's no harm in mentioning getting saying that from the medical legal point of view. I think we have a documentation. But like sir said, like Rajiv sir said, we are mostly going to grow the normal common cells. But if you are lucky, I mean, if you grow some gram-negative organism or like like he said, actinomyces or something else, some gram-positive, some
But
gram-positive.
Manoj, many times what happens is that we may grow some organism, but it is the colony count that they are looking at. And beyond a certain level, probably the microbiologist would advise you, caution you not to do surgery now.
Yeah.
So number of colonies are what is important sometimes. All right, but it is not very important is what betadine prophylaxis is what is important. We briefly discussed about the pre-operative antibiotics. So more and more evidence is coming on both for intravitreal injections and even for cataract surgery. There's no use of topical antibiotics because it's a clean surgery. Many surgeons worldwide, many institutions have it in their institutional policy that they are not going to use pre-operative or post-operative topical antibiotics for cataract surgery. But having said that, all of us use. Some of us even go to the extent of using systemic antibiotics in some troubled cases, right? So that is a legal protection that we are seeking. But currently, in the scenario where we are using topical antibiotics, what do you think would be I would just have one word from each of the panel. What would be their choice in preoperative prophylaxis? Do they start preoperatively? Or intraoperative, would they do an intracameral antibiotic and what is their choice? And post-operative topical antibiotic, what is their choice? One by one single word answer. Yeah, Aditya, can you start?
Sir, I use moxifloxacin 24 hours prior to the surgery.
Okay.
And intracameral only if I have a PC rent.
Okay. All right.
Post-operatively, I use moxifloxacin, and
Okay.
that works well for.
Okay. Kiran?
Yes, sir. The same thing that he has said. We start with
Any change?
before
Pooja,
that.
any change?
Preoperatively, moxifloxacin, yes, sir, both intravitreal injections and also for cataract surgery. Intracameral, we do give, sir, vancomycin. To give intracameral vancomycin.
For all patients?
Yes, sir, for all patients. For all cataract patients, we do give intracameral vancomycin. And post-op, it is always preferable to give not a combination with steroid because it increases more resistance. Maybe we can give antibiotic only for 2 weeks and steroid maybe we can taper. But then when it comes to cost effectiveness, then definitely we should think into it.
Yeah. Pratik?
I am not giving pre-operative antibiotics. I'm starting on the day of surgery, and I'm doing intracameral moxi in all the patients. Okay. Post-operatively, I'll give separate antibiotics and steroids.
Okay, Manoj?
I think almost the same. Moxifloxacin 1 day pre-operatively. Intraoperatively, we always give intracameral moxifloxacin. Post-operatively, I think we follow both the AO and the ESARS guidelines say that no, you should give an post-operative antibiotics for 1 to 2 weeks. They're a little vague about it, so we do give it. We give moxifloxacin
Sure.
for 1 to 2
Raju
weeks.
sir and Hemant sir, any change?
I think the only care I would suggest, is when you give intracameral, I think I should alert you for the problems that are known with vancomycin. So, intracameral vancomycin is
Sorry,
associated.
Vigamox is preferable. So sorry, I was mistaken.
Yeah. I think
Point
I
one.
just wanted to,
Yeah,
caution you.
point one
Yeah,
intracameral
I
Vigamox.
know
Sorry.
most of them use moxifloxacin. I actually, for my
Ceftazidime
intravitreal
would be
injection,
better.
sorry.
Oromox.
Yeah, the
Not discuss
intravitreal.
companies. Let's not discuss companies, please.
Yeah. The intravitreal injections, I don't give anything. I feel it's justified not to give because I think studies have shown that you have a higher incidence in if you start it. So I don't give it. In cataract surgery, I don't think they are starting it, but I'm not very clear. I think my cataract surgeon should know. But I think they are more insisted on intracameral moxifloxacin, and post-operatively they cover with antibiotics. So I think that's what they follow strictly.
I would just like to say that moxifloxacin currently has a lot of resistance, and even before systemic
Correct.
moxifloxacin came in, I think we as ophthalmologists have been significantly
Yes,
responsible and
problem.
solely responsible for having the upper GI, upper respiratory and GI tract completely resistant to moxifloxacin by overuse in pre-operative, post-operative cases. Gatifloxacin, though, doesn't have a systemic gatifloxacin because it was withdrawn from the market. And so gatifloxacin, even 0.5 percentage, which is higher concentration, may be a little better because it will not, there is no systemic gatifloxacin to develop a resistance to. So that is my 2 cents on it. Yeah, Rajiv sir wanted to say something before we move to the next topic.
There was a case of endophthalmitis where intracameral was not given. The judge said you have gone wrong in not giving an intracameral because now it has become a norm. Because everywhere, especially after the Arvind study, they have found that 5 times decrease in endophthalmitis. When you can give it, it's a small dose. Why did you not give? Was the question asked in that particular case. That was one case from Tamil Nadu.
Yeah, I think more and more evidence coming in, and more people have started using intracameral moxifloxacin through the surgery.
European Society of Cataract and Refractive Surgeons recently have also recommended cefuroxime as intracameral 1 mg per 0.5 ml will decrease 5-fold decrease, sir, as sir said, as sir rightly said. Yes.
Yeah, can I add one thing that, I agree with you that, earlier I was very strict about this, that in our hospital, we used to not use moxifloxacin topically because I always dreaded that we need to use some of the things for our intravitreal usage in case of infection. So we used to use gatifloxacin and tobramycin as our drugs, which anyway has no systemic, drugs available. So it used to work very well. We used to use it regularly as our post-operative antibiotic. But I think things do change over a period of time. But I always feel that we should try to reduce our antibiotic usage, especially the higher ones, because we are ultimately going to need some of these for treating our infections. We are now not having anything now. We are going to develop resistance to most of these antibiotics. There's virtually abuse of antibiotics in our country, unfortunately.
The next major topic that we will go through would be the operation theater, which I think Rajiv sir has covered quite well. Laminar flow theater versus normal OR, one table in one OT versus multiple tables in one theater. What are the number of AC changes per hour? Rajiv sir, can you just, for the sake of the audience again, can you just mention about these things?
Say there should be adequate space. For a ophthalmic theater, it should be around 200 to 250 square feet, and the number of people in the theater should be not more than 5 to 6 is what is recommended, because the air change is about 20 per minute, So then when you increase the number of personnel in the theater, the bacterial load increases. So if you have a proper HEPA filter with HVAC system, the air quality will be maintained throughout. So even if you have a large volume of cases, still the quality, even the first case or the last case will have the same quality of air. But whereas in a split AC or anything, after your fifth or sixth case, the bacterial load, there was a study done in Arvind where they did the culturing after first case, the fifth case, the 10th case, and the 20th case. They found that the growth was enormous at the end of 20th case in a split out. So all these things is important that we have. If you have a split AC, limit your number of cases. Don't do high volume. If you are looking for high volume, go in for the laminar flow system. And that is important. And proper masking is very, very important. And use of mobile phones should be strictly avoided in the theater because makes
it's a museum of all bacteria.
Yeah.
So let me also ask you again about the duration of hand wash with betadine versus chlorhexidine. And if somebody has a betadine allergy, then what would they do?
Betadine allergy, the other option is chlorhexidine only.
Yeah.
But chlorhexidine is an alcohol-based hand hygiene system, which works within a minute. Whereas Povidone-iodine, it takes 3 minutes for it to act as. I've seen people, washing 3 times. They 1 minute, wash away, then again one. They think by washing 3 times they are extra care, but they are making a mistake. It's like boiling an egg 3 times, 33 centigrade, ultimately 100. But that contact time should be 3. And please don't mix with water. Some of them they take betadine, add water to froth it because your dilution will go down. It is 10%. It has to act at 10% only. So when you add water, it becomes diluted to become 2 or 3%, which will not have any effect. And all the steps, especially the web spaces, everything, you might wonder why you're going to wear gloves. And why the hell you need to scrub so much and all. But all these gloves have micropores. And if by chance there is some puncturing or something in your glove, the chances of endophthalmitis, the hand is something like your sterile instrument going to the eye. Your hand should be as good as that. So hand hygiene should be given equal importance.
Now about the preparation of the patient. We talked about, please Manoj, please.
One point that I wanted to add is because I know the audience listening, they may not have, many of them may not have a dedicated, ophthalm theater. So they may be sharing the theater with other faculties. So it's important that we try and have as much as possible a dedicated theater, or at least find out which was the previous surgery that happened there. Right, we would not expect no cardiologist, no intervention cardiologist will give their theater to somebody else. They keep it very, very clean. So similarly, we should try to have a dedicated theater, because when you do it in a multi-faculty setup, there's a possibility that you're operating. There's a surgeon who had operated and on some infective case, and then on afternoon you go to do a cataract there. So these problems can be there. So that is something that has to be remembered. And another thing that I want to say, sir mentioned about split AC versus a centralized air conditioning unit. Many theaters do have split ACs. So the Arvind study, though initially they did find, like what sir said, they also come out with a recent publication where they clearly show that once you have povidone-iodine prophylaxis and once you have intracameral moxifloxacin, then the incidence of endophthalmitis is similar across a centrally air conditioned unit or in a split air conditioning unit. So that means that these two factors seems to be the most important factors in preventing endophthalmitis.
Yeah, thank you very much, Manoj. So let us move to intraoperative preparation to the patient. Betadine, as Dr. Rajiv said, currently we should have a 3-minute contact time. So what is the percentage of betadine that you will use in the conjunctival cul-de-sac? Will you do it before you wheel in the patient to the theater, or on the table you put drops on the patient's eyes and wait for 3 minutes? What is the usual technique that is followed?
Actually, when the patient is waiting outside with the topical anesthetic, you can apply 1 or 2 drops of povidone-iodine outside itself, so that
This is 5%.
5% is what is used in conjunctive.
Yeah.
For scrub, it is 10%.
Yeah.
Okay, and then repeat it again. By the time when you drape, you just apply it, wait for a minute or two, and then by the time you drape, it will be 3 minutes.
Yeah, that time will you apply 5% or 10%?
No, 5% only.
5%. On the conjunctiva,
On
because
the
betadine is
conjunctiva.
also corneotoxic.
Corneotoxic. 10% is corneotoxic.
Okay, and for patients with betadine allergy, we can use probably spirit, right?
Spirit
Alcohol-based
is,
drugs.
no, it will damage the epithelium.
No, on the skin. I mean,
on the skin, okay.
Yeah. Then you will not use on the conjunctiva, definitely. Yeah.
Very rarely I've come across them. In my practice in 32 years, I've never seen a betadine allergy.
That is because when we are to give injections, many of these patients receive repeated injections. And every time you clean with betadine, sometimes you see betadine allergy. So when we use that betadine on the skin of that patient, definitely there will be an edema there. So we test those patients on the forearm skin or something like that. There will be some betadine allergy coming in, because we have to repeatedly, like unlike cataract surgery, here you have to give many times, right? So that is a problem then. All right. So topical versus peribulbar anesthesia. Dr. Pooja, your view on topical versus peribulbar. Will the risk of infection be higher with topical versus peribulbar? Because in topical, the patient's eyes is mobile, probably the wound integrity, all those things are peribulbar. The patient is much more quieter, and you are able to very clearly seal the wound. And any difference?
Overall, it should decrease our time of duration of surgery. So yes, if the patient is comfortable, then maybe yes, you would go with topical. And then if the surgeon is confident with finishing the duration of surgery, then definitely yes.
But actually, I also think that it is the doctor's preference, topical versus peribulbar, and obviously the patient comfort when we evaluate them preoperatively, like if they are able to withstand that. All right. Okay. Any irrigation solution of choice? Any takers on that? Dr. Pratik, would you want to talk about the irrigation solution that you would use?
So I'm using the routine BSS solution only, but we are not giving any antibiotics in the solutions. ESCR study had showed it had no benefit.
Yeah, some people use gentamicin or some other antibiotic into the solution, which is not to be encouraged, right? Then preoperatively, we do not start the patient on systemic antibiotics, right? Yeah. Clear corneal versus sclerocorneal incision. Raju sir.
Definitely, the incidence of endophthalmitis is more with clear corneal. It has been documented. But the importance is sealing the wound. How tightly you seal and make sure it is. Suppose you're in doubt, put a suture. That's what. Definitely, the incidence is slightly, not very high, more with clear corneal compared to sclerocorneal.
But most surgeons are comfortable with the clear corneal faster. It doesn't require dissection, and they are able to seal the wound very well. So superior versus temporal?
Definitely superior has got less endophthalmitis than temporal. Temporal has got a slightly higher incidence of, because the patient can press like this.
Yeah. So these are things that are very small, but people should know, right? Yeah. Then
patching versus no patch.
Yes.
There again, it doesn't make any difference at all. Actually, patching causes a little bit of corneal edema and all. So patient is much more comfortable. Maybe for an hour or two, you can patch if there is little irritation immediately after surgery. It doesn't that doesn't have any effect on the ultimate outcome as far as endophthalmitis is concerned.
Yeah. So one thing that we always do, which is reuse disposable instruments. Many of the times the companies would say these are to be used once, but most of the people in India and a lot of people across the world reuse these instruments sterilized. So
that can be used provided you sterilize it properly. See, so for example, cutters. So they are very expensive, you know. Can you ETO it and do it again as far as it is sharp enough to do it? I personally feel there's no harm in doing it, but don't reuse it without sterilizing. That's what I wanted to convey.
Yes, yes.
The problem with reusing instruments is not task. You know, sometimes you can end up with a task because when you
Task
have
also.
cannulated instruments, you have these material that,
Remnants.
like, whatever disinfectant that you use and all that can be inside and can incite. So that is something that is not the ECR study did not find any difference in endophthalmitis between reusable and disposable instruments, provided they had all received intracameral cefuroxime.
Yeah.
So
Whenever we are
The
reusing
question
tubings
is
after
not
sterilization,
usable
after
and disposable. Disposable being reused.
used, yeah.
Yeah. Whenever we are reusing the disposable tubings, the problem is we need to be very, very much, cleaning the inside of the tubes. Because otherwise, what happens is that whatever was there in the previous surgery will come in, even though you surface sterilize it. So the tubes, inside of the tubes have to be sterilized quite well. Rajiv sir, can you add one point on that?
And there is air jet pumps are there, which we can use it for cleaning tubings. Then unless it's dry, autoclave doesn't work. If it is wet, see, it should be only on dry surface, the autoclave works. Autoclave or for that matter, ETO also. So jets are there, which can be used. Air jet pumps are there, which can be used for but the companies, they don't recommend them because it damages the lumen of the tubings.
Okay.
So, but for practical purpose, this can be done if you want to reuse it.
Okay.
Though it's a controversy, Gopal, about patching. I know it's like most of us do not advocate that, but we cannot compare with the data from the West because our environment is different, our
Correct.
patient profile is different. Like many of us are like people working in remote areas, where patient hygiene is different, and when they travel back from the hospital, to their place, it's long distance they have to travel. So in
I
these environments,
completely agree with you, Manoj, because our environment is completely different. The transport environment and even the home environment may be different in underprivileged people. And so, and we are trivializing the whole
By not
surgery
patching.
by, not patching and asking them to go for work tomorrow, etc., etc. Yeah. Yeah. Moving on to the next thing, which should be any type of intraocular lens like polypropylene or hydrophobic versus hydrophilic. We only have Aditya. Aditya is the other cataract surgeon here. Yeah.
I usually prefer injectors, sir, hydrophobic, and mostly it's a pre-filled. I mean, if you have to place the IOL in the injector and then inject, there is some chance of some risk, but if it's a preloaded, the risk comes down.
Okay.
That is handling is talking about. You're not going to handle the intraocular. The question here is hydrophobic versus hydrophilic. Hydrophobic is always in fluid because the chances of fungal growth in a fluid is always there. And the incidence of TARS has been reported in recent times to a very large extent because of a hydrophobic. I think it should be banned. There's no more role of hydrophobic because it's got no added advantage or on over hydrophilic.
Hydrophilic or hydrophobic? Hydrophilic, right?
Philic. Sorry, I went wrong in this.
Hydrophilic is the one that is more chance of
dangerous.
And polypropylene also is found to, attract bacteria and.
So single piece lens are better than.
The ECRS did not find a difference. The ECRS study did not find a difference between. They found that silicon-based IOLs and PMMAs had more endophthalmitis risk than acrylic lenses. But between hydrophilic and hydrophobic, they did not have. And again, as Dr. Aditya pointed out, injector, they did not find a difference. But anyway, different set of surgeons, different environment. I don't think we can exactly replicate that. But anyway, these are guidelines.
Intraoperative antibiotics, we were very clear after the Arvind study, large volume study has come out. All of us would want our cataract surgeons to use intracameral antibiotic moxifloxacin. Some people definitely from the ESR study before that use cefuroxime, but of late, I think more and more cataract surgeons are using intracameral moxifloxacin. Subconjunctival antibiotics generally not so much used, but some people are still using. Earlier, people used to use quite commonly. Antibiotic in irrigation fluid no longer used. Right now, any complications like vitreous loss, nucleus drop, or PC rent with ACIOL, definitely. Then, what are the other precautions that you would do so that the infection chances are lessened? Yeah, Aditya, you can take that.
Sir, first I would inject some tricot and make sure there is no vitreous in the anterior chamber after a posterior capsular rupture. And then the next step is I will inject to be safe, I will inject intracameral moxifloxacin. And at the end of the surgery also, I will make sure there is no incarceration of any vitreous in the wound site. And post-op steroids, I'll make sure I'll be giving steroids to bring down the inflammation and which prevents post-operative inflammation.
Okay, longer surgery versus shorter surgery. Obviously,
Shorter
shorter surgery, less risk of endophthalmitis. Longer surgery, you are exposing the anterior chamber to the bacteria, and probably end of risk is slightly higher. Kiran and Pratik, Pooja, everybody would agree to this. Manoj, Rajiv sir, all fine.
Yeah, yes,
Okay,
sir.
so let's move to the next area, which would be post-operative care. Okay. So we just discussed about goggles versus patch. So I would not go into it. How long to patch? Maybe 2 hours, maybe till the patient reaches home, or maybe till next day morning. Generally, people would not want to keep 24 hours because we can start topical antibiotics, right? What do you think, Raju sir?
I normally start about 4 hours after the surgery. Till then, I keep it patched. Because most of my cases I do subtenon or peribulbar. So for that sake alone, if it is topical, maybe 1 hour or 2 hours later, I remove the patch and start on topical and give them separately. Topical antibiotic. What I use is moxifloxacin and along with prednisolone acetate. So initially, I give it for first day, I give it 2 hourly. Then second day onwards, it's 4th hour. And
Hemant sir,
review them after a week.
Yeah, yeah. Okay, Hemant sir, now we have a patient who underwent a reasonably good cataract surgery. Day one, you are clean 6/6, and fourth day, fifth day, he complains of some pain. Sixth day, he comes with 4/60 vision with cornea edematous, etc. So how would you initially assess that patient, and day one, day zero, you're counseling to that patient? Because it is very important how we talk to the patient is also very, that is one of the most important thing, catastrophic thing, which can actually cause a lot of problems. So how do you counsel this patient?
No, I think once you see them initially, they had good vision, they have loss of vision, and there are signs indicating that there is endophthalmitis. I think we should accept it. We tell our patients that this is the problem that you have. This could be occur because of various reasons. We'll have to look into how we can treat the patient. So I think we need to tell them about there is a problem in the eye, and tell them that they need to be on close observation. We need to treat them and see that we are able to get over this problem as soon as possible. I think some of them do understand, because nowadays we do tell them that possibility of infection is there in most eye surgeries. So patients are aware of it. So I think once you tell them, they are very clear. I think keeping them in the dark is where all the problem comes. We should, and own this problem, this thing, and take the responsibility of ensuring that they are treated. So we give them also explain the steps of treatment, and then we go ahead with it.
Yeah. Basically, all of us being retinal surgeons who do treat them, it would be more easier for us to talk about that. I think Rajiv sir and all would find it a little difficult because he has to refer this patient. So how do you counsel the patient, sir?
Me?
Yeah.
So, thank God, in my 30 years, I had only one endophthalmitis, which I managed it very well. I got in touch with the vitreoretinal surgeon. Yeah, always you have to have a good rapport with the vitreoretinal surgeon, whoever it is, maybe Gopal or somebody else. Okay, keep them in good books and get the best advice of it, and give them the clear picture, send them a picture, communicate with them, and intracameral I gave, and then I referred the patient, and vitrectomy was done, and the patient regained complete vision. But the entire process was taken care of by me. Actually, I drove the patient myself to the vitreoretinal surgeon. I didn't leave it to them. I assured them that I'll take care of you. I took the bystander also into confidence, told them that nothing will happen. We'll take care of it. Some infection has come. And they were blaming themselves because they said, I rubbed my eye. That's why this happened. It was lucky for me that way. No, they didn't blame me at all for that. That too came on the third day of the, and it happened to be Pseudomonas. And the response was very good. Vitrectomy was done and presented with counting fingers close to me. And what I did was, as soon as the patient came, it was around 10 o'clock. Every 10-15 minutes, I applied Bradford for it. And I found that hypopyon was drastically improving with, increasing with. So I confirmed the diagnosis, gave intravitreal, vitrectomy done, and the patient we get complete vision. That was the one case which I had. That was way back. After that, I got into this theater sterilization classes, and I was educating everybody about the theater. Unless otherwise you experience it, you'll not know what it is.
Okay. Okay, Pooja. Day one, corneal edema, significant corneal edema, some AC reaction. You are worried about TAS versus actual endophthalmitis. What would be your take? How would you differentiate between the two? And what would be your management?
The amount of pain the patient has, vision, anti-segment findings, especially very bad hypopyon, always get a B scan done for such patients if the posterior segment is involved or not. The amount of pain and the amount of vision drop will definitely help you to differentiate whether it is TAS or it is end-off.
All right. So TAS generally does not involve the vitreous cavity so much. So vitreous inflammation. But 25% of the endophthalmitis patient in the EVA study did not present with pain at all. So that is also, so lack of pain should not be taken as absence of endophthalmitis. That is the only thing. So TAS is more into the anterior segment. So vitreous inflammation will be much less. So a vitreous ultrasound will show that vitreous is reasonably clear. All right. Any other point, Manoj or Hemant sir?
Limbus to limbus corneal edema and high intraocular pressure. I think that these two things will be quite in favor of TAS.
Yes, please. I think that's important. Actually, you get
happening.
typically corneal edema as a major finding in TAS, and that's what should alert you that there could be a possibility. And it's generally the first post-op day that you see it.
Okay. So in such cases, Rajiv sir has a train to catch, I think. Okay, sir. Thank you very much for your keynote address, which I think all of us should rewind and hear again and again. Thank you very much.
Sorry, I have to travel. I'm going to Palakkad for tomorrow's CME. Okay. Good night, everybody.
Okay.
Nice.
Yeah, good night. Good night. Nice talk. Good night.
Thank you.
Yeah. So the next thing is, when you are faced with a situation where there by 18, which dropped from 6/6 to 6/18. At this point of time, what is your day zero plan? I would start with Prateek. Prateek, what would be your day zero plan? Would you considering 6 by 6 drop to 6 by 18 over maybe 3 or 4 days? And there is very mild vitritis, which you cannot very clearly assess because of anterior chamber reaction. Ultrasound is equivocal. I mean, it is not so much echoes or anything like that. So would you want to, this is a case of doubt. So in this case of doubt, will you heighten the antibiotic and topical steroids, or would you add an intravitreal antibiotic in this situation?
So I missed the initial portion. Is this a complicated surgery or an uncomplicated surgery?
It's an uncomplicated surgery with 6 by 6 post-op day one, which after 3 or 4 days reduced to somewhere around 6 by 18 with a lot of anterior chamber reaction.
So if that was uncomplicated surgery, in the day one, I will not directly jump to an intravitreal, keep the patient on frequent steroids and have a closer follow-up. But if the patient is worsening with that, then I will add an intravitreal antibiotic.
Okay. So I would just like to add that, day 3 or day 4, if somebody has an endophthalmitis, generally either the virulence is high or the dose of the organism is high, which means both of which are not bad. They are quite bad for the eye. So even if the dose is high or the virulence is high, it is going to very rapidly progress. So the first 6 hours, probably you need to very carefully observe. The first 6 hours, we need to very carefully observe. Can you hear me?
Yeah, we can hear you.
Yes, we can hear you, but
Your signal is
Yeah.
Yeah. Yeah. So the first 6 hours, we have to very carefully observe because very rapidly it can worsen. So maybe topical antibiotics and steroids every hour, and probably day 3, day 4, you are not looking at fungus. You can add steroids to reduce the inflammation, systemic steroids to reduce the inflammation. Wait for maybe 6 hours and see if it is not improving in the way you want it to improve. Definitely, I would like to add intravitreal injections, intravitreal antibiotics. My first choice again would be vancomycin and ceftazidime. And in case of very fulminant infections like Manoj was telling earlier, we may add a meropenem or something like that. Any difference in opinions?
I think Gopal, I think you pointed out a very correct thing that like if you have an exaggerated inflammation happening in the first week after cataract surgery, that is when we have a confusion whether it's related to the post-operative course, the intraoperative course, or whether we are dealing with an early fulminant infection. So I think here now the role of posterior segment involvement is very important. And once you do an ultrasound and if you see a slightest suspicion of a posterior segment involvement, or like when you use the EVS guidelines of they have defined what a gram-negative ENTOF looks like, and we use those guidelines. And if it fits into that, we should have a high degree of suspicion, and it is always better to err on the side of infection. There's no harm in giving an intravitreal in these situations. Especially if you're seeing somebody else's post-op cases, like suppose a patient you see they operated somewhere and you really don't know what happened, intraoperatively there. These are situations, when you should have a high degree of suspicion and treat it as endophthalmitis, because you don't want to miss a fulminant, organism.
Kiran, I would just want to ask you, when will you suspect fungus? Like seeing what is the situation? What is the usual type of patient who comes in? When will he present, and what would be the findings?
so usually the fungal they present very late, maybe after the 1 or 2 months. They may not have typical severe pain and redness like normally seen in the bacterial one. They're usually very slow paced and a lot of vitreous haze, and in the findings like the hypopyon will be there, but in the vitreous you'll see more of a haze and the cotton ball appearance and such fluffy materials in the vitreous. And usually the course is very slow, and they may not respond very well to the topical steroids that you give. In those conditions, we have to suspect steroids, and also we have to keep in mind the other chronic late onset causes like Propionibacterium acnes too. They can also present very late without much, and they respond very well to steroid too. So maybe we should pay attention to the bag, see any precipitates when we're suspecting any Propionibacterium acne infections. And the treatment also might differ when it is such a case with the approach. The typical, I mean, we'll have to take the sample and inject, but maybe we should try to get a PCR also done in these cases, but because in a case of propionibacterium, the culture may not be positive all the time. Like the PCR yield will be much better than uh, the cultures. So I would also want to know like how often we should, advise PCR, because the culture positivity rate is pretty, I mean, is around 30 to 60%. So should we advise PCR for all the cases of
The
end of
problem is
our.
about cost. That is the only problem. But if a person is affordable, definitely a multi-PCR with 25 organisms straight on. Now there are newer PCR methodologies available where you can also get a sensitivity pattern of the antibiotic. So that would be also very useful, and you will get it within 24 hours rather than waiting. But culture has its own merits also, because out of these 25 organisms, if there is any other strange organism, you will never get it in a multi-PCR. Yeah, Manoj.
We do get the sensitivity too. Yeah.
No, no, I was just thinking about reflecting on my experience dealing with fungal endophthalmitis. So one thing is, these patients, may not have the typical vitreous inflammation. You see them at 3 or 4 weeks post-op, and many of them have very indolent anterior segment inflammation. So these are patients who you just think that it is some kind of a mild inflammation, put them on steroids, and they don't do well with steroids. And my experience is that now when you do a vitreous tap in these patients, now often even the PCR turns out to be negative. So what we do is whenever we see a suspect of fungal endophthalmitis, we do definitely both an AC tap and vitreous tap, and we find that the load of organism in the AC tap is definitely more in fungal cases than in the routine, bacterial endophthalmitis. So that is one thing. So this again answers Dr. Kiran's question. But this is one area where we would like to do a PCR because when you suspect fungal, because the cultures will take a long time to grow. You cannot wait. You have a suspicion, and you don't know. You're not decided whether you want to give an intravitreal oriconazole, and then the PCR you get the result by 24 hours, and then you have an answer at least whether to go in for an aggressive management. But then you need to think of a more aggressive management, even removing the IOL, the bag, because these fungal organisms are usually sequestered within the bag, and you need to be very aggressive in managing these patients.
Yeah, thank you, Manoj. So, Hemant sir, I would like to give a descriptive methodology for intravitreal injection, because intravitreal injection is a key to the first treatment of earliest treatment for endophthalmitis, which will alter the prognosis of that patient significantly. So can you explain the methodology of injection? What needle are you going to use? What type of syringe are you going to use? Would you use vitrectomy for cutting or tap? How much vitreous should come out, and how much antibiotic to be used? Can you just describe the methodology in about 2 minutes?
So the thing is like this, that I think it all depends on the setup. So I know that in my setup, I would do it slightly differently because we are retinal surgeons. So I feel an adequate sample is only available. You get a sample only if you do with a cutter. So, if your view is not clear, you generally just take a sample from the core, vitreous, and try to get the sample, because if the cornea is hazy, you're probably not going to do a vitrectomy. You'll not be able to see anything. Sometimes by clearing the anterior segment, you do get adequate view for you to continue with vitrectomy. Otherwise, you just do just debulk the core of the vitreous and then give intravitreal antibiotics. In that situation, obviously, because you already have a port, it doesn't matter. You inject through the port. But otherwise, let's say for a general ophthalmologist, what would happen is it depends a lot on the intraocular pressure. So remember that for you to inject, the eye should have some degree of reduction in the pressure. That's going to be the key. Now, in a situation wherein your AC is not going to be visualized very well and it's going to be difficult. So if you try doing a tap, generally most of the taps are negative, because the size of the needle is what will determine. If you put a larger needle, it's going to be more difficult. A 24 gauge needle is probably the ideal trade-off between what you should use. It generally is difficult to aspirate the vitreous because fluid vitreous is very less in most patients. So to get that tap, you need to at least get the pressure a bit down. And then we inject the intravitreal antibiotics by using a 30 gauge needle with the 1 cc syringe. But one should remember that you should have a chart in your OT which gives you the dilution method and the dose that you are going to inject for all these uh, drugs. Remember that you have to put it on your it should be available to you in the OT, because when you are injecting, actually that is the key time that you need to really know whether my dose is correct and I'm going to inject, because that is where all the problems come. People just don't realize that at the last minute they try to do something, it's not going to work. So you have to have each drug and their have a dose, and if dilution is to be done, what is the method of dilution for each of them?
Okay, thank you, sir. So generally, we will use a 1 cc syringe, 3.5 millimeters from the limbus, use a 24 gauge needle to aspirate. Aspirate at least 0.1 to 0.2, and then send for, if you have to send for PCR as well as culture, probably you'll have to aspirate a little more, but aspirate from the core of the vitreous. Don't go near the edges, because the retina may be already detached and you may cause more problems. And then inject slowly using 30 gauge, or maybe remove the syringe and put it, reintroduce it and inject 0.1 ml of the antibiotic. And as sir said, manage the intraocular pressures, because that will have a bearing on the postoperative pain also for the patient. All right. So now coming to vitrectomy, Manoj, what do you think are the current indications? There are a lot. EVS was done long back, and so what would be the current indications for a vitrectomy?
And as Dr. Hemant Murthy initially mentioned, I think as we are surgeons now, we are more confident to do early vitrectomy in these patients. So because we know that the clearing the vitreous is the most important act when you manage a patient with endophthalmitis. So my tendency is to do an early vitrectomy in these situations after like the initial the first if it does not happen at the busy part of the day, I would start off by giving straight away by doing a vitrectomy in these patients. So that will be my choice, doing an early vitrectomy. And again, the question of
Is there
whether
a visual acuity cutoff that you use?
no
Nothing.
I don't
So
use.
if there is end off, you are thinking in terms of, if your diagnosis is end off, early
Yes.
vitrectomy is your answer.
Yes. If I have diagnosed an endophthalmitis and vision is not a criteria for me, if there is a doubt, I would still get a tap done and wait for a day or something. But if there's an opportunity to do a vitrectomy, I would go ahead and perform a vitrectomy as early as
Okay,
possible.
debulking the vitreous, removing the dose of the bacterial organism or the fungus inside, very rapidly countering the inflammation, giving an antibiotic as far as possible, as fast as possible, taking out maximum material out of the vitreous so that we have much more material for culture, sensitivity, PCR, whatever. So all these advantages are there for vitrectomy for a seasoned surgeon like yourself. But for an early surgeon, maybe vitrectomy in endophthalmitis is also one of the most difficult surgeries, because the retina is quite friable, fragile, vitreous is inflamed, and PVD induction may be a little difficult in endophthalmitis. So all those pros and cons needs to be weighed. So the way you or I manage would be a little different from way a budding surgeon may manage it. Okay, Aditya, can you tell us a bit about how you would be managing the vitreous in endophthalmitis? You unmute, please.
Usually we do core vitrectomy, but if it is if I can do a good vitrectomy where I can induce a PVD and clear the entire exudation, I will go for removal of the entire thing. And if there are any breaks or the retina is if the retina is involved, if and there are any breaks, I would prefer some I would inject some silicone oil and then come.
Okay, so as far as possible, you would try to do a complete vitrectomy.
Yeah.
But if the vitreous is not easily, PVD is not easily inducible, you will
Core
stop
vitrectomy,
short at
inject.
that. And
Yeah.
so all patients you will give silicone oil, or in some
No,
select patients you will give silicone oil.
only in patients where there are some inadvertent breaks, retinal breaks.
Okay, so if there is a retinal break or something like that, or suspicion of a retinal break or detachment, then definitely you will use oil. Okay, Kiran, how would you be managing the intraocular lens? Would you want to remove the lens in the first sitting, or do you want to retain the lens, clean the lens, and maybe put antibiotic all around the lens and keep it there? What is your thought process on that?
In all the cases, I would like to keep the intraocular lens. Maybe only in only one situation where I would like to change, remove is only in cases like propionine, where if it is not responding to the injection, then the last resort will be to remove the bag and the lens. But even then, there are other ways where you can just do a partial capsulectomy and infuse the medicine into the bag, and maybe you can retain the lens. But that is the only situation where I would go for a removal of the lens. Otherwise, I leave the lens as such, but maybe I'll try to remove the membranes in front of the lens, and wash off the hypopyon. Otherwise, the lens is untouched.
Okay, so you would like to retain the lens in the first sitting, and maybe if you're going for a second surgery where there's a resistant end off, that is a point, or if fungus bar propionibacterium end off, then that would be a time when you would want to remove. Dr. Pooja, can you say what would be your thought process in putting silicone oil for the patient? Is it only for in the presence of retinal breaks or tears or detachment, or you would clean up and then put silicone oil in all cases?
Not for all cases. Not all cases, sir. Not all cases.
All right.
Definitely not for all cases.
Okay, generally
Only for retinal break.
silicone oil will also help in, it has got some anti-infective purpose because it doesn't allow the bacteria to go into the, so there is some evidence to say that. So in very severe cases of endophthalmitis where retina actually shows retinitis, I would consider silicone oil, apart from those cases in which there is a tear or a break or something like that. I would like to ask Pratik, what would be your take on antibiotics after vitrectomy? What would be the dosage? Would you have to reduce the dosage, or because now the concentration, now you have removed the vitreous en toto, and so yeah.
So the literature usually suggests that we have to give half the dose of intravitreal after vitrectomy. So that is what I'm doing to avoid excessive toxicity to the retina, because most of the exudations have already come out.
Okay. Okay, Manoj and Hemant sir, any more pearls of wisdom to give the audience regarding vitrectomy in endophthalmitis?
No, I think you have covered most of the points very well. I think most of the things have been covered in this session. I think very well brought out in terms of every aspect, including the OT aspect, the pre-post operative, care that we need to take. I think all of it has been covered very well. It's nice to go through this meeting.
Manoj?
And I think I agree with sir. I think it has been very exhaustive. We have covered everything. We tried to cover just 2 hours. We tried to cover every bit of situations that can happen. I think it was overall a very satisfying meeting.
I would just like to complete it by saying that we need to manage the patient. It is not about treating the end of, we need to manage the patient and the patient party, including the bystanders, because they may be very volatile and they may come charging at the hospital. A lot of problems can occur. So the dialogue with the patient and the patient party is very, very important. And you need to break the news honestly. But probably a little sugarcoat it. I would little bit sugarcoat it by telling that there is a reaction, there is a possibility of infection. Let us get a culture done, and if possible, we should clean the vitreous of the infection. So if you say immediately surgery versus cleaning, the impact that it makes on the patient and the bystanders are a little different. So dialogue, especially when you are dealing with some other surgeon who has referred you a case, and you make some small careless dialogue, actually the people will go back there and bash that particular person. So careful dialogue is very, very important in managing the patient. And as I said, early diagnosis and act fast. These are the two important things. Intravitreal injection to be given as early as possible. And like Manoj said, now things are changing because our instrumentations are also much better. And as our experience is also improving, early vitrectomy will provide the patient with a significant advantage in terms of final visual outcome. Thank you very much, all of you. Hemant sir, Manoj, Aditya, Prateek, Kiran, Pooja, and my three junior fellows, Asla, Ashwati, and Grishma. Thank you very much, AIOS, for this opportunity for us to be a part of this panel discussion. Thank you very much.
Thank you, Gopal. I think you have moderated the session extremely well. Thanks to you. And yeah, thank you, everyone.
Thank you. Good night.
Good night. Good night.